Let's continue with the meeting. I apologize to the Labor Department. We compressed the discussion time for the previous agenda item, hoping to start this one early because of the coronavirus pandemic. We're very concerned about occupational disease. We would like to have more time for the discussion of this item. Item 5. Prescription of occupational disease and occupational health situation in 2019. The Labor Department has submitted a paper. It's CB-282/19-20-05. We have with us Mr. Jeff Leung, Deputy Commissioner for Labor. He will take us through the paper before we take questions from members. The Labor Department would like to take the opportunity to introduce to members the occupational disease situation in 2019. There are 442 cases in 2019. The common ones are occupational deafness, silicosis, tendinophysitis. Well, the numbers are 58, 38, and 10 and 6 cases. Well, it doesn't mean that the situation is worse because of the long latent period of certain occupational diseases. On the other hand, we have enhanced publicity and public education, so there is enhanced awareness. In 2019, the Labor Department continued to roll out different publicity campaigns to enhance awareness and knowledge of various occupational diseases. It's getting hotter and hotter in Hong Kong. The Labor Department is very concerned about the hazard of heat stroke to employees that may be exposed to very hot weather. On education and training, starting from May last year, we have started a 5-month large-scale promotion campaign on heat stroke prevention. We distributed protective equipment, we broadcast a new publicity video, and we publicize potential hazards of working in very hot weather to workers. In relation to employees who have to stand for a very long time and the health hazards, in December 2018, the Labor Department has rolled out the guidance notes on standing at work and service counter design to remind employees and employers to address the hazards properly. The guidance notes states that employers must, as far as reasonably practicable, provide suitable work chairs or chairs for occasional resting at work locations. Since the rolling out of the guidance notes, we have, on top of large-scale publicity, conducted a lot of inspections. We have conducted about 300 inspections and issued 18 warnings. They cover mainly failure to provide chairs to employees and failure to suitably arrange employees to take rest by sitting while at work. Apart from that, as the chairperson said, we would like to talk to you about this prescription of occupational diseases and their criteria. When we prescribe a certain disease as occupational illness or disease, we have to draw reference from the International Labour Organization criteria. We have to make use of an evidence-based requirement to find out whether there is a specific causal relationship with exposure and whether the risk of the disease occurring among the exposed workers is significantly higher than that in the rest of the population. We also have to look at the occupational origin of the disease and the population. There are lots of voices asking for COVID-19 to be prescribed as occupational disease. We will have to abide by the international standard, that is, to establish that if employees contract COVID-19, we can reasonably deduce that it is contracted through work and not through other means. Employers will have to pay compensation. Well, given the fact that COVID-19 is still evolving in Hong Kong and globally, we will keep a close watch on medical and epidemiological data, especially the number of cases originated from work and the industry distribution, as well as the extent of community infection, in order to make necessary recommendations. Currently, COVID-19 is occupational disease that should be compensated. However, employees may, under the Employment Compensation Ordinance, ask for compensation should they contract an illness. If an employee contracts COVID-19 in the line of work, they should inform the employer as soon as possible for notification to the Labor Department, even though it is not currently a prescribed compensable occupational disease. 7 members would like to ask questions. I'll read out their names: Andrew WAN, Michael LUK Chung-hung, Fernando Zhang Xiu-Ka-chun, Kokaki Leung Yu-chung. First round, we have ample time, 5 minutes, each question and answers included. Thank you. I have 2 questions. The Deputy Commissioner has already talked about this. We are very concerned about COVID-19. I'm not going to go into detail about the definition. Well, according to the list 1.3 of International Labour Organization, one of them is a communicable disease. 1.3.9 specifically said that for those other biological reasons, biological illnesses, if it is medically proved that there is a direct correlation between the work and the contraction of the illness. It has more clearly stated that it may not be a scheduled disease, but it should be included in the scope. In short, it means that COVID-19 or Wuhan pneumonia should be included. Well, you talk about Section 36 of the Employment Compensation Ordinance. It's rather vague, and people may ask for compensation or not. Page 3, you mentioned about Sars, 415 healthcare workers. Well, for that case, it's a very clear cut. And it's not because of employees' compensation, it's because of a settlement they have reached. It is a semi-public organization. On principle, it seems that it is in line with employees' compensation, but not really. I think it is easier for you to just make it a listed disease. Compared to 2005 during SARS, well, Hong Kong is hard hit. Well, the impact on the rest of the world is rather small, but so far, number of confirmed cases is 1.2 million for COVID-19.
So when you ask the people around the world, the impact of COVID-19 is greater than SARS. So can the administration provide us with a reply that shows your dedication in including COVID-19 protection to cleaners or medical workers? And you should also make reference to the ILO definition of biological factors in making the list of occupational diseases. Commissioner, the latest, there's a case coming from a local case coming from a worker in the airport. So other than medical workers or cleaners, maybe these frontline workers should also be considered. Thank you for the question from member and chairman. the occupational disease listed by the ILO for each place requires scientific evidence. So there are two major considerations. First, is there agents at work that will be contacted by the employees in the workplace? That's the first factor to be considered. So from this perspective, we can see particular sectors may be high risk. So these conditions may be satisfied. But there are also another consideration factor. The second factor is about the causal relationship between the exposure and the contraction of the disease. So the contraction rate have to be benchmarked against the general infection rate in a wider community. So during SARS, the contraction rate for those sectors are particularly higher than the general contraction rate. But for the COVID-19, the causal relationship between the workplace activity and the contraction has not been established. We don't know whether they contract the virus from the social life or from the workplace. So only until we can establish these causal relationship can we include COVID-19 into the list of occupational diseases. Thank you, Chairman. Next, Michael Luke. Chairman, some frontline health workers are infected with the COVID-19. And in this epidemic, as compared to the epidemics before, not a lot of health workers are infected. But it doesn't mean we don't have to pay attention to this COVID-19 epidemic. I think the administration should be open to include the COVID-19 as an occupational disease. I think we have consensus across parties. If the host committee can operate normally, I think it's not a difficult task for us to get the bill passed to include the COVID-19 as part of the occupational diseases. If the combat against epidemic is going to be a long battle, then we will need such an inclusion. Now only 52 are included as occupational diseases. A lot of diseases are actually left out from the list. If the disease is not on the list, the workers' unions may not be able to offer help, and the employees may get undercompensated. For example, heat strokes during working. In mainland China is included as occupational disease, but in Hong Kong it's not. And also the harm to the legs from long time standing. For example, the local courier services workers, they may have overused the legs, but they are not protected. Or death from overworking. Maybe we include that. We should also include that. So I think the administration should take a more open attitude in trying to include more diseases. So I think a more comprehensive review has to be conducted. Thank you, Chairman and members' question. So as I mentioned, we have to follow the ILO standard in considering whether to include a particular disease as occupational disease. So we are continually reviewing the list we are having, and in the past 2 decades, we have added 13 diseases onto the list. And we have colleagues overseeing the new suggestions made by the ILO, and also Hong Kong's particular situation on infectious diseases. So all these efforts are being made to try to include more diseases onto the list. So we will continue our work on this front. Thank you, Chairman. Chairman, I don't understand. If you follow the ILO standards, as I mentioned, for example, heat strokes are included, so why do you not include that? So, for example, heat stroke, is it excluded in many areas, or do you have another view? So, heat strokes are common for construction workers, or in factories, or doing welding work. They are exposed to that risk. Because you talk about heat stroke prevention, but it's not yet an occupational disease, it's quite paradoxical. Thank you, Chairman. And members' question. As I mentioned, the Labour Department has to consider a array of factors in deciding whether to include a disease onto the list. So different places have a difference in pharmacology or epidemiology. So going back to heat stroke. So if employees show symptoms of heat stroke, should we include those symptoms directly as a confirmed case of heat stroke? So if they, for example, fainted from heat or feel dizzy from heat, that may not necessarily be heat stroke. So thank you, Chairman. So heat stroke is a staged process. So first they may feel dizzy and they may feel unwell in the body, and in serious cases they may lose consciousness. But when we're looking at the heat pressure, or to say heat stroke, the employees can still claim, according to Section 36 of the Employees' Compensation Ordinance, they can claim that under Section 36 because it's a harm arising from work, as defined in the ordinance. Chairman, I want to draw attention to, for example, the practices in the mainland China and Taiwan. They include the permanent damage from heat as the part of the coverage. Michael, you want to ask in the next round of questioning. Thank you, Chairman. We are now looking at the inclusion into occupational diseases list, and we're wondering why COVID-19 cannot be included as an occupational disease. So I refer to the Secretary's saying, he said, I initially thought it would be an easy issue to tackle, and I didn't realize the complexity of the issue in the beginning. And the Undersecretary told a different story. He said the ILO standards have to be followed. I raise an example, the single ear deafness. It is not included in the standard. So you can include the COVID-19 beyond the guideline provided by the ILO. By including that is an encouragement being provided to the workers exposed to the COVID-19 risks. So I'm not sure what kind of figures are you waiting for. Do you have to wait for a death arising from work because of COVID-19? Second, you say when in the process of legislation you would consult insurance industry or employers, but would you consider starting those work earlier, even before legislation work begins? So there are 415 medical workers' claim arising from Sars, and ultimately they're all resolved by the LD. But actually 10% out of that have not been resolved. So any additional information for that?
I'd like to also follow up on something that you mentioned, the guidance notes on standing at work. Well, we think that it is not appropriate to not include wear and tear in the lower limbs, but you issue a guidance notes. You said in 2019 there were 281 inspections and issued 18 warnings. What type of trades are these 18 warnings issued to? Is it the case that several of them have been issued to one single employer, or there are 18 different employers? Thank you. Just now, Mr. Poon asked a number of questions, and I will answer them one by one. We will closely monitor some data, but they are not a number of deaths, as the member said. If we list a disease as occupational disease, it means that someone contracting the disease in the course of work, thereby rendering a loss of ability to work, there will be compensation. We don't just look at the overall number of contractions in Hong Kong. We have to find out the number of cases that are confirmed in relation to confirmed cases of people that have contracted in the arising out of work, or the illness is contracted in a social setting. We have to look at these factors. We attach a lot of importance to the data, because if we list a certain illness as an occupational disease, we have to make sure that there is a clear causal relationship. Once it is listed, there is no need to investigate into the origin of the disease, because it's already confirmed by having it listed that the illness is contracted arising out of employment. That's why the employer has to make compensation. Regarding when we will conduct consultation, as far as we know that the Labour Department is still collecting necessary information for the Labour Department to have a comprehensive view on the situation, as well as the way forward before we decide when and how to conduct a consultation. We have heard members, and we will pick up our pace. We will closely liaise with the Department of Health about the latest situation of the illness. Well, there may be 30 or so cases out of 415 are not directly resolved. I would defer to Mr. Lee, the Assistant Commissioner, for further information. From the information I have about the cases in SARS, the Labor Department received 415 cases. 415 cases. Close to 90% were settled because the employer admitted liability and are willing to make compensation. 372 of them. And in the end, about 35 of them had to go to court. There are healthcare workers, 5 of them that work under the hospital authority, and the other 7 cases work for other employers. There are 31 cases with that the employee decided not to pursue with the assistance of the Labor Department. 18 of them are healthcare workers and 13 of them are non-healthcare workers. There's some historical information. Dr. Fernando Zhang. The definition of the ILO is rather clear. There are 2 parts. But it says that it is some kind of illness that is related to specific work environment or work activities under which employees are exposed to. So the working environment or the work activity is related on a causal relationship with the disease. Regarding whether COVID-19 is related to a specific working environment or work activity is rather clear. It is a communicable disease. It can be transmitted human to human. In an enclosed environment, if someone is working there and is in close contact with an infected person, there is a very clear causal relationship. And the second leg of that is that the risk of the disease occurring among the exposed workers is significantly higher than that of the rest of the population. So, engaging in a specific type of work activity in an enclosed environment of close contact, is there a higher risk than the rest of the population? I think if you look everywhere in the world, you see it very clearly. Even a kindergarten kid or a primary school kid will know. Well, under the COVID-19, of course, healthcare workers are exposed to a risk higher than the rest of the population. We should not even engage in a debate about that. In an enclosed environment, if one is in close contact with a possible carrier, of course the risk is higher. If you look at the case in Hong Kong, where there are cabin crew members working in an enclosed environment, being in close contact with possible patients, drivers or foreign domestic workers. If the employer is infected, how can the foreign domestic worker escape from the contraction inside that home? So clearly it fits the definition of the ILO. I don't know what the administration is still waiting for, what kind of data. You may say, well, there are just less than a handful of healthcare workers who have been infected. We're not talking about the sheer number of infection. We're talking about the risk and the causal relationship in the working environment or work activity, if we provide healthcare workers with sufficient personal protective gear, and if in the end very few of them are infected, does it mean that we don't have to afford them with the protection? Whether it is listed or not, there is a huge difference. Say, for example, the difference in conditions for sick leave and the difference in compensation. Why can't we give that protection to high-risk work? For Legionnaire's disease is a communicable disease and is listed. It's something to do with hot and cold water system, because it's a kind of mold living in the water tank. So for certain type of workers, they stand a higher risk. Over the years, how many cases of infection are there? Tell me. If there is no causal relationship, then why do we have to work from home? The government asks us to work from home because there is a causal relationship. You don't need to collect data. Well, we've been doing work from home for 2 months, so how come you still have not established the causal relationship? In relation to the comparison of the Legionnaire's disease and COVID-19, I will defer to our doctor. The major difference of the two is that in relation to COVID-19, we have a large-scale community transmission. That is a significant difference from Legionnaire's disease. I'll defer to the doctor for further details. I agree that in certain work environment, indeed, the workers may be exposed to high risk. Say, healthcare workers, they have to come into contact with suspected cases or confirmed cases. In prescribing an occupational illness by the ILO, they advise that you will have to look at the morbidity rate and compare it with other sectors to see if it is higher. So if we look at COVID-19, we have to see how the situation unfolds. We have to see whether there will be a certain type of workers who will contract the illness more often than others. We have to collect the data before we decide that workers in that work environment, if there is contraction of the disease more often than not, it is contracted arising out of employment. Because if it is listed as an occupational disease, the employer will have to make compensation directly. That is the major difference from employees' compensation ordinance. We have to establish the causal relationship. Say, for example, there are 10 people in this trade. All 10 of them have contracted the illness. They are from the same trade. However, in the end, the investigation found out that 9 of them contracted the disease in a social setting. Only 1 of them contracted the illness in a work setting. But if we have listed that disease as an occupational disease, that means all 10 of them, because of the nature of work, will receive compensation from the employer. This is not in line with the ILO's basic principle. We have to wait for the data before we decide whether COVID-19 should be prescribed as occupational disease. Legionnaire's disease and COVID-19 are 2 different diseases. the number of cases is related to the number of workers exposed to this. If there is a higher number of people in that environment, if there is higher morbidity rate, we'll have to decide. So we have to carry out investigations. I do agree with the doctor. Well, it talks about the principle, not the number of cases. Just now, the assistant commissioner said the exact opposite. Why don't you simply answer me? In the past few years, what is the number of people who have contracted Legionnaires' disease? It is listed as an occupational disease. Is it because of a high number of cases? No, whether there is a significant risk. Well, if there are local cases, you can take reference from the local cases. If there are no local cases, we can draw reference from overseas literature and information. And if they can apply to Hong Kong, then we will take that into account before deciding whether it is an occupational disease. As I've explained, that there may not be many local cases. It depends on how frequent one encounters the disease. Well, you will have time. You can go to the second round.
So you may follow up later. We also have a motion from Dr. Fernando Cheung. So Leung Yu Chung, Aaron Kwok, and now is Pt2. Thank you, Chairman. It's only after hearing from Commissioner that I know the administration respects the definitions in the ILO so much. Not sure if I remember correctly. Is Sars an occupational disease back then? If so, why did you define Sars as an occupational disease? You just stressed on the causal relationship, and you even said it has to be the single cause of for the harm being done. So, applying this strict standard, why was Sars being able to be identified as an occupational disease? And Malaysia and Canada have identified COVID-19 as an occupational disease, and Belgium, French, and South Africa and South Korea, they have all speeded up the process by helping the employees get compensation out of COVID-19. But what about Hong Kong's administration? What are you going to do to help the employees to get compensated for COVID-19? Your explanation is they can still have the right under Employees Compensation Ordinance. But I want to point out the fallacy in your suggestion. Because COVID-19 is now not on the list in Schedule 2, they have an burden to raise evidence in order to prove their case now. So they are now not relieved of the evidential burden. So don't try to confuse us with the non-occupational disease claim. This is two different issues. So we also cover the laboratory workers and healthcare workers. And even those for funeral services or border control or the transport workers, these are all high-risk industries under the COVID-19 epidemic. So what can you do for them? I would invite Deputy Commissioner Lee, Mr. Lee, to comment on the situation on employees' compensation, and I will respond to the issue on Sars. Back then, we also adopted the same principle. The outbreak of Sars was in 2003. The LD back then had to have full set of data about the incidence rate. We have to make sure they got the disease from work, and we have the data on the sectors, industries, etc. And it's only after those processes we identify SARS as an occupational disease. About 1,700 of cases, 22% are healthcare workers. So these 22% is a very high percentage, as in accordance with the principle in the ILO. So that explains why SARS was an occupational disease listed. Next, regarding the reports on the practices by foreign countries. Based on our own research, I'll give you an example. Italy. So Italy have 117k cases, confirmed cases now, and 17k of that healthcare workers. And in Malaysia, there is also one outbreak group that involves healthcare workers. So I want to point out they have their own specific situations. And on how and what we can do for employees. I want to reiterate, once we list a disease under Schedule 2, it means we establish the causal relationship between the work and the disease with utter confidence. That explains why we can relieve them of the evidential burden. So upon establishing such a causal relationship firmly, there's no way for us to put a disease under the list. Commissioner Mr. Lee, thank you, Chairman. Now we still have the Section 36 protection. Under Section 36, I'm going to elaborate now. Under Section 36, even though the disease is non-occupational, but if it's caused, the death or the injury was caused by their work, they can still make the claim. So member has just said, or be concerned about the evidential burden under Section 36. So the evidential burden will be discharged by the information not only from the employees, but also the circumstantial evidence collected by the LD. The circumstantial evidence or other evidence may include their health situation, or on point, the consent of the employees. We can have the tracker's report about the medical situation of the particular employee. So all these array of information would help us confirm the discharge of the evidential burden. I want to know if you provide any assistance in helping the employees during the SARS epidemic. During SARS, we provide assistance, and now, according to the DH advice, we contact the employees affected by the COVID-19. So we'll start from the reported cases and track down the case we have to follow up. Chairman, can they give us a written reply? Sure. Thank you. Dr. K. Kok is away, so we give the time to Leung Yu Chung. Thank you, Chairman. Hong Kong's situation is quite different from other places. We have a lot of imported cases in Hong Kong. Local infections are relatively rare. But the lower local infection numbers doesn't imply the absence of risk for frontline workers. You look at the example in the airport, and also look at the members of the band from that outbreak group. So in all these examples, you can see the causal relationship between the work and the disease and the COVID-19 infection. It's only luck that some of them are safe from being infected. They are actually exposed to high risk of the COVID-19. They are only not infected because they wear masks or pure luck. I don't want you to hinge your inclusion with large number of extravagant number of infections. I don't want us to wait for until deaths occur. We have long criticized this approach. In one example, when they eat, they take off their masks, and they are actually exposed to the risk of droplets and infection of the disease. So again, it's a matter of luck they don't get infected. So you have to consider the risk instead of the actual confirmed case. You cannot compare the COVID-19 situation to SARS, because back in the SARS time, we don't have enough awareness. So from the experience of SARS, we already know the importance of the awareness and risk prevention. So don't adopt a consequentialist approach. You look at the risk and look at risk prevention. I don't care if it's only one confirmed case, you still have to protect the employees from the risk of infection. So this is my view. So turning to other occupational diseases. So the number of cases for occupational diseases have been increasing, including, for example, deafness. Even if you look at the past 5 years figures, they have been increasing all along. So is it because the OD has not done a good job? I may defer to Dr. WAN to respond to the deafness issue. Not only deafness, but all the other occupational diseases have been on the rise. So I now defer to Dr. WAN to answer members' question with regard to a particular occupational disease. He may point out the particular causes for that. And in response to members' concern about whether the risk alone is enough for us to include COVID-19 onto the list under Schedule 2, I think it will be difficult for us. Because the principles and the insistence on causal relationship, as mentioned, is very critical, because it involves almost automatic compensation being made by employers. Quick interruption. Excuse me. Because now, for each or most of the confirmed case, we can track the source down. Even when you look at the news reports, the sources are identifiable. The sources may be their home, or maybe the ventilation system. So I just want to say the sources can be identified.
The Department of Health is doing their best to understand the source of infection, whether there is a transmission path. Well, we would like to get the information before we decide the next step. As Mr. Leung said, well, with the work of the Department of Health, maybe they are able to find out the source of the infection in each case. In relation to employees' protection, as Mr. Lee said, with the consent of the patient, we would be able to get the information. If we find that the source of infection is from work, under the current protection compensation mechanism, the employer has to pay compensation because the employee contracts the illness in arising out of work. Perhaps Dr. WAN can explain about the increasing number of cases. In the past 2 years, the major increase comes from occupational deafness. Well, there is also a spike in gas poisoning. Occupational deafness is a chronic illness, and that will manifest itself over a very long time. At the beginning, the symptoms are not very noticeable, so the person themselves or their family members might not notice. With the publicity of the Occupational Illness Compensation Board, employees will be made more aware of the situation and compensation available. Then they would go and file a case and make applications for compensation. There may be a huge fluctuation in the number of reported cases every year. That depends on the understanding or awareness of employees. Maybe over a period of time there was more publicity, so more people became aware of it and report the cases. There is a huge increase in the number of gas poisoning because of 4 incidents. One of them involved, as you may recall, there is a case of gas leaking. About 12 people were affected. That explains the spike in the number of cases. We have Mr. Kok Wai Keung, Dr. Pierre Chan, and I myself. I have received 2 motions, one from Dr. Fernando Zhang and another one from Mr. Michael Luk and Mr. Poon Siu Ping. We will put them to the vote in about 15 to 20 minutes. We just have our quorum. So if you leave, please come back in 15 or to 20 minutes to deal with the motion. Next, Mr. Kwok Wai Keung. Thank you. Today, the Labour Department refuses to list COVID-19 as an occupational disease for mainly two reasons. First, it's difficult to establish the source of the contraction. Two, they have to consider the affordability of employers. If you look at the schedule of occupational diseases for category 2 biological agents, well, a number of people have talked about the Legionnaires' disease, and there is also this respiratory syndrome. There's also avian flu A. If you refer to B11, that is the acute respiratory illness or syndrome, there are 5 categories. Well, you will have to be in a healthcare setting, taking care of patients, or you have to take care of known patients. Say, for example, they're frail, you have to feed them. C, you have to identify, you have to investigate, you have to detain, you have to isolate these patients. D, you engage in investigative work, or E, you work in a lab. So you don't just look at the name, you have to look at the area of work. So for the acute respiratory syndrome, if you just change the name of the disease, then you can list COVID-19 as occupational disease because you specified the nature of work. I don't understand why the Labour Department will deviate from what's already written down. And they have repeated a number of times that they have to think for employers. A lot of people have been commenting, well, how come that it is the Labour Department, but they're working for employers? Should they change their name? It's something simple. How come that they can't even do it? I'm not asking you to make something up. It's already there. Sars has already been included. All the elements are similar, and there are also restrictions. We have employers, which is the HA, and the government. Are you saying that the hospital authority and the government, being the largest employer, do not want to shoulder the responsibility? If it is not that difficult, and if it is so similar, how come you still look for excuses? No one wants to get ill. No one wants to contract this illness that may threaten your life. Why can't you just give us that, Commissioner? Well, when we present this agenda item, it doesn't mean that we have already rejected. We have to take into account the development of the pandemic and whether there is sufficient data for us to establish it. The member asked, why can't we just simply add it like SARS? I tried to explain. SARS was listed as an occupational disease because back in 2003, there was close to 22% of the cases were healthcare workers, which is a higher percentage than the rest of the population. Hence, we think there is sufficient evidence for it to be listed. In the future, if healthcare workers contract SARS, well, then the employer has to make compensation. If there are 10 people in the same trade, and it's found that 9 of them contracted the illness not from the work setting but in a social setting, only 1 of them contracted the illness because of employment, and if we list that as an occupational disease requiring employers to make compensation directly, this will not be in line with the mechanism. We already have a mechanism to deal with the contraction of illness out of employment, that is under the Employees Compensation Ordinance. There are no evidence showing that the mechanism is failing. These cases can be dealt with. If you were only listed when there is a high number of cases, are you waiting for a high number of cases? Even if you can protect 1 person, that is enough. Can you explain to me about proper protection? I don't agree that currently there is no protection. Our protection is only a mask. Next, Mr. Pt2. What you said sent chills down our spine. I just returned from a hospital. And if that's what government officials said, then, well, we don't feel very hopeful. During SARS, mainland China, Hong Kong, Singapore, Taiwan, Canada, well, Hong Kong has the highest infection rate. You find that there are a number of cases, there are a number of places that have reacted really quickly now because of the lesson they have learned. Taiwan have lost a lot of people. Hong Kong have lost a lot of people. And we also have seen a number of cases of recovered cases that are still suffering. The official line to take is, well, let's wait for more infections before we make a decision. That is rather indifferent and cold. Are you asking for local data or data from other places? You see that in other places there is a large number of cases involving death of amongst healthcare workers. We talk about border control and the wearing of masks. Your boss, the chief executive, said, well, the WHO said this and that. And let me tell you what WHO said on their website in relation to coronavirus. They said that regarding healthcare workers, they are exposed to risks because of the virus, the work environment, and also environmental factors. The WHO website says that this document is about how to protect healthcare workers, including occupational safety and health. You may refer to the WHO website. Your boss often cites WHO. My question is, are you looking only at local data, or you will also consider the characteristics of the virus? We will take into account the characteristics of the virus, the outbreak situation in overseas countries, or whether there are lots of people who have contracted the illness in their line of work. We have to also consider Hong Kong's situation. Let me point out that, well, overseas situations might be important, but whether they decide to list it as an occupational disease may cover other considerations, say, for example, the operation of their own employees' protection mechanism. Every place is different. You will have to consider the local situation. You should not just look at one factor. We have to have a comprehensive view before we can have an objective analysis. You keep talking about establishing a causal relationship, whether there is a higher percentage. You mentioned about 22%. From the information you have, in other places, the percentage of infection of healthcare workers and the rest of the population, have you collected information on that? I thank the member for the question. In the past few months, past 2 or 3 months, every day we read WHO information. We keep in view on the news and the latest information of other places. We haven't reached a stage where we have comprehensive information to see the whole picture. We don't have that yet, although we will keep that. We will keep monitoring the information. You mentioned about 22% of number of infected healthcare workers during SARS. If you don't have the information, find it for us. In other places of the world, what is the percentage of healthcare workers being infected? You just use that as an excuse and your shield. I will not just let you go so easily. If you find the information, give it to the LegCo. We see a high percentage of infection and fatality in certain occupational groups, say healthcare workers. We're talking about something that is occurring, but you turn a blind eye to it. If you don't have the information, it doesn't matter. Go back, find it, and give it to us. As we said at the outset, we have been monitoring the situation, but it doesn't mean that we have all the information available. We'll continue to monitor the situation. And even if we have all the information today, don't forget that the pandemic is still evolving. In a lot of places, the situation hasn't peaked yet. We have to keep in view what's happening overseas, whether there will be a high infection rate amongst a certain type of workers. I ask members who are here to return in 5 to 10 minutes because we have 2 motions to deal with. I have 5 minutes. We have answered 9 members' questions. I think maybe you were asked the wrong question. You were asked whether there is a high percentage to prove that there is a relationship. People used SARS. I think it's a wrong question. It's not really in relation to a particular job. It's whether it's related to going to work. I think it is a more profound question. If you go to work, you may get infected. That's why government officials, civil servants will have to work from home. And we have social distancing. Is that not a causal relationship? If there is none, how come that there are 12 occupations that are exempted? Because we know that going to work is a route of transmission. So if you go to work, you may get infected. You should not ask what type of jobs before you decide whether it is an occupational disease.
I think Chairman's question is about the risk of going to work in general. So these issues exactly the focus we are on. Because the epidemic is everywhere. If you go traveling, you go to a bar, you go sing karaoke. These are all areas of risks. So by that logic, do we have to include all employees across industries under the compensation scheme? Shouldn't it be done? It's because if the scheme is going to be that all-encompassing, it will be not in line with the ILO principles. Commissioner, we see police officers contracting the disease from their work. And also, those working in that bar have contracted the disease from work. And if the staff in the airport are absent from work, they would not have contracted the disease. That's what you are saying, but does that mean Hong Kong just have to be on a deadlock, on a lockdown, total lockdown? We're not in a total lockdown. So as long as all those people working, all of us are working, we are exposed to the risk because of our work. We are not going to parties, to the beach for to play. We are working and we get the risk of the disease from our work. We are not like civil servants who can work from home for months. We have to go out to go to work. So we are constantly exposed to the risk of infection. I cannot make sense of what you have been saying in this whole meeting. I don't know why the causal relationship is still not seen by you. Thank you, Chairman, but I have reiterated the difference in the risk exposed to different industries. And I also said risk is only one of the factors to be considered for the inclusion under Schedule 2. Right now you mention the airport example. I think you cannot just look at the venue of work to say there must be a causal relationship. Maybe only one out of all, to say 100 infected cases get the disease from the work. The others may get from the bar, from other social venues. But if the disease is under the scheme, all the 100,000 of workers who got the disease will be compensated. Commissioner, I just want to make one point clear, that the employer can object to the compensation, right? That's correct. Yeah, that's what I'm saying. Chairman, I just want to reiterate the importance of the causal relationship. That's the foundation for the Employees' Compensation Ordinance, Schedule 2. Dr. Keokok, please. I want to ask the Deputy Commissioner so what you said are the same as the Secretary. So what WHO standards are you referring to? Thank you, Dr. Gary Kwok. There are two parts to the WHO guidelines. First, with regard to working environment. So, the employees are exposed to the risk of infection in his or her workplace. So, a lot of industries fall under these first condition. So, this condition is rather easily satisfied, but the point comes from the second condition. The second condition is the incidence rate for a particular industry has to be much higher than the incidence rate in the general population. Commissioner in 2010, in the 307th session of the WHO meeting, they just mentioned a causal relationship. And what they said is you only have to find a particular substance to which the employees are exposed to in the workplace. You only have to prove the employees would be in touch with that substance at work. Or in another way, in the workplace, the employees have to be in particular contact in the workplace. It's different from what you have mentioned. Only contact has to be proved, and only scientific evidence is needed for the contact to be proved. And COVID-19 falls under all those conditions. Italy, the first case for Italy is found later than Hong Kong. And Italy has already put the COVID-19 under a list of occupational disease, and Germany is 4 days later in finding its first confirmed case. But Germany has already included the protection for healthcare workers. In South Africa, first case is 5th of March. In Canada, Belgium, they all find their cases. First confirmed case is later than Hong Kong, but they have already all put the COVID-19 under the occupational disease list. So, Commissioner, do you think you are above all of them? Do you think you're smarter than all of those countries in operating the mechanism of including the COVID-19 as occupational disease? What have they done wrong so that you don't consider their practices? Thank you, but I'm afraid I cannot comment on the practices of other countries. I can only draw on our own research. Italy has 170,000 confirmed cases, and 10% of them are healthcare workers. Commissioner, I'm a doctor. How can I say the healthcare workers are absorbed of the risk of infection? So we're doctors, same as the one sitting next to you. You show no care for their well-being. They're exposed to the risk every day. Chairman, I refer you back to the ILO guidelines. The risk of infection is only one factor. The incidence rate for that industry relative to the general population's incidence rate is the second condition. It's bullshit. The aircraft workers may be exposed to risk only when they get on the planes, but healthcare workers are or at all time being exposed to the risk of infection. It's not the same as what you said. Healthcare workers are being punished by your stubbornness. And the fibrosis of the lung tissues are being overlooked by you. We must put all these in records. It's so inhumane. So we received 2 motions. The first is from Dr. Fernando Cheung. So please, Dr. Fernando Cheung, bring up your motion. Because of the epidemic of the COVID-19, which clearly complies with the ILO's requirements for occupational disease, this panel urges the government to include the COVID-19 as an occupational disease under Schedule 2. So please raise hands for those who are for. So unanimous endorsement.
The second motion is moved by Mr. Michael Luk, seconded by Poon Siu Ping. Who is going to read it out? Mr. Luk. Given the fact that COVID-19 is very serious at the moment, especially to people who are working frontline, this has posed serious occupational health and safety risk to Hong Kong employees. We ask the government to show that their responsibility and to provide sufficient personal protective gear to employees, as well as to list COVID-19 as an occupational disease in order to enhance occupational safety and health, as well as labor welfare. Hands up, please. Unanimous. Commissioner, please forward the unanimously endorsed motions to your department and consider listing it as an occupational illness, occupational disease. Thank you. Item 5 is finished. There is no other business. Meeting adjourned. Thank you.